Welcome to today's Talking Point. I'm your guest, Neaz Ahmed. Our guest today is Professor Tim Eden. He is an oncologist, internationally known, but his journey to this destination has been rather long. He started from pediatrics to leukemia to cancer. How long has this journey has been, and how momentous and exciting?
Well, I qualified in 1970, and after a little bit of wiggling around to see what I wanted to do, I've been in this business for about 40 years now. And we went from a period when children in this country and Europe and America had little chance of survival.
We're talking about London, England.
Yes, London, England, absolutely. But children back in the 1960s, we didn't know whether they could be cured. And now 4 out of 5 are cured long term. But sadly, that only applies to high-income countries.
Yeah.
And one of the challenges, as I've gone through my career, has been to see, along with a lot of other willing colleagues, is to say, can we also help in those countries that are low and middle-income countries where cancer begins to emerge, particularly when you start to deal with infections and the problems that kill young children, then cancer emerges as a real challenge to their lives. And
But you didn't start this right away. I mean,
No.
clinical practice, research and training and teaching.
Absolutely.
And then you
Well, what happened?
came to this field.
Absolutely, but what happened, I started in 1974, so it is exactly, well, coming up for 40 years, in this area. But you're quite right, I was training and I was beginning to do some research. I went to Stanford University in California, where it was really already being developed, particularly for lymphoma, which I've been very interested in. And I worked there as a fellow and then came back to Britain. But in '79, I was first appointed as a consultant in Bristol. And then I moved back to Edinburgh, where I did a lot of my training in 1982. Subsequently, I've moved elsewhere, and I've been privileged to be appointed as a professor in London. At Barts in London in the early 90s. And then I moved to Manchester. And I held 2 posts in Manchester. I was the professor of pediatric oncology, and then in 2005, not long before I was planning to retire, I was actually appointed as the Teenage Cancer Trust professor there, because what we'd been doing for children we could see was necessary for teenagers and young adults. So I began to become back into doing adult work as well. But not older people, but just younger adults.
Is there any particular reason why teenage or younger persons catch or say develop cancers?
That's a long story to answer that one, but we think children's cancer, and in fact many of the cancers that occur in teenagers, are quite different to the adult cancers that we see in old age. I mean, the average age for getting cancer is somewhere between 55 and 65.
Right.
And that's a sort of wear and tear thing, that your tissues get broken down
like
and
people
damaged.
Have prostates and bladder.
Absolutely. Or smoking related, like lung cancer and so on. But we think for many of the childhood cancers and some of the early teenage cancers, that the first abnormalities that occur when the baby is being put together.
Could it be genetic?
Well, I think you have to be careful about using that term genetic. A small percentage, about 5 in every 100, may have some genetic familial, but not more than that. And I think most don't, but the genes can be rearranged. It's not transmitted, it's just by accident when things, it's a miracle that we're all normal actually, or relatively normal. But, speaking for myself, I know that I've got a few, my ears aren't both the same size and we're asymmetrical. So I think when we're being put together, but sometimes we know that the genes get rearranged. And that is a bit like a time bomb waiting to happen. But thankfully, it's very rare. Children's cancer amounts for, in this country, only about 1% of all cancers. So it is relatively rare, but...
When you say in this country, that means high income.
Yes, exactly. I should be very clear.
Logically, it's probably higher in low income group countries.
Well, we don't know that. We don't know that, and the reason we don't know that is that in high-income countries we have data registration. Cancer in Britain, universal cancer registration, so we ascertain almost all the patients, near enough 100%, so we know who's
so
get cancer
the knowledge
everywhere.
And there's just a lack of knowledge.
Exactly, but very few countries, particularly low-income countries, very few of those in the world have true population registries. So the answer is we calculate, but if you, the World Health Organization have a group called IARC that actually work out of Geneva, that do all the statistics and what we call epidemiology, the study of disease, and they reckon that the range is 80 to 150 per million children get cancer. Now, that's quite a wide range. We know that in this country we're at the higher level in high-income countries, and we know that where in developing countries that it may be only 80 per million, but that may be not true. It may be that there are lots of cases don't come. So when we calculate in Bangladesh, we think there's far more patients that are actually seen with cancer, and many people will be...
I think you have mentioned in your work somewhere that out of 160 million people, 47% are under 16.
Absolutely.
So that's a big chunk of population.
Very much so.
Almost 50%.
Absolutely.
They're under 16 and more likely to suffer the disease unreported.
Well, we think that there must be far more patients that are missed than actually come. But what is interesting is that when we have started our work with Bangladesh, that we're seeing more patients.
2004?
Well, I've been going backwards and forwards and been working, and they have been developing. But we started our current project with World Child Cancer Project in 2012, so it's very recent. But even in the first year, their baseline level was 250 new patients. It's now nearer 400, so more patients are coming to the unit, and I think that is a reflection on raising awareness, and people I don't think the incidence is necessarily going up. I think that people are being recognized as having cancer, and that is one of the fundamental issues. When I go back to the 60s, many patients used to come when I was a medical student, and then early on in the 70s when I was a doctor, many patients would come with their tumors, with solid tumors, very late with big disease, big lumps.
Because they were not aware of what it was.
They're not aware, absolutely. And not only were they not aware, but also the doctors weren't aware who saw them. GPs and even doctors in hospital didn't know, and they'd say, well, it's a lump, we're not sure what it is. And we've done quite a few studies looking at that even, and even now...
There was no facility for biopsy those days?
Well, people thought it was a sports injury or swelling, a nasty lump, you've fallen over or something, and so there were some of those things were missed, but that is decreasing, thankfully, and people do come earlier. But in low-income countries, people may not come at all, or they may come too late to be treated, and that is a big problem. We know that is a problem in Dhaka, that there's a significant number of patients come eventually to hospital, and then they have very advanced disease and they cannot have any chance of cure, which is really tragedy, actually.
It's because we don't have an NHS-like system which really can detect at an earlier stage, see?
Well, I think, I mean, there's several things that relate to survival. One is being aware of it and actually access to diagnosis. The second is being access to treatment, and thirdly is using effective treatment. So all those three things come into place. But I think we're trying in all of the projects. We work in 6 countries at the moment fully for projects, and we have another group of countries where we help them with the data registration. But the countries where we work, we're trying to raise awareness through the media, through radio, through television, through
literature,
workshops, prints, posters, banners, whatever way we can. We know that, for example, in Africa where we work, radio is the real answer, because television is okay in the cities, but radio, people listen to the... I was just talking
it's
to
cheap, easy to run.
Absolutely.
Accessible.
very much so. And we were just talking to some people about Malawi the other day, because we have a project there, and the Zodiac radio, that's the one to go in, because that's the popular one. And if you can get messages on there, you know, if you've got this problem, go to the doctor. And we also target women, actually, because women, there are certain stages in their life where women obviously go to health clinics, to the community health, for, you know, when they're pregnant. Right. And when their children have vaccinations. So they're a better target. Men don't go to doctors very often in low-income countries unless they're really ill.
Yes, because it costs money.
Yes, exactly. So, but women will go and be seen by somebody. So we try to target the community nurses, the community clinical officers who might see them at the time of vaccination or of pregnancy or whatever, to try to get them to recognise that that child coincidentally has got a lump. We should send them.
Yeah, I mean, a health concern in those countries, third world countries, is of lowest concern and of low priority, because money comes in consideration. Housing, food, education, clothing, and then if you can walk, it's good enough.
Yes,
you're healthy. See?
Absolutely. No, very much so. And I think the problem is that children very often, not only are they maybe not diagnosed with something that can be cured, and in many places cured at affordable cost, you may have to subsidize them, and we do that as part of our projects in World Child Cancer, but actually they'll be suffering. They'll have pain. You know, children have as much pain as we as adults. And
they just can't tell us.
They can't tell us. And it is really quite shocking that more children don't get relief of symptoms. Worldwide, this is one of the big challenges. There's lots of stigma associated with giving a child or actually taking things like opiates, which are for pain relief. Children do not become addicts if they're in pain and they have the pain relief. They become happy and you then stop it when you've treated the tumour.
So they're not taking it voluntarily, they are being given.
Well, exactly. And there is quite an amazing statistic that 92% of the world's therapeutic opiates are used in just a dozen countries. High-income countries, basically, so that in most countries it doesn't get out. Even if you prescribe in the hospital,
but the stuff comes from third world countries.
Absolutely. Well, we could have debate of that completely. That is really one of the tragedies, where most of the opiates come from countries that never use opiates themselves.
They're happy exporting it.
Yes, absolutely. Well, don't get me going. It's true.
How interesting. Back in 1994, as you said somewhere on your website, you were recruited away to Manchester, and then it was one of the largest regional units and you were appointed Professor of Pediatric Oncology.
Yes.
You developed a strong clinical practice, and you had the enthusiasm for teaching and leading to cancer in younger people. This and other stuff we'll talk about after the break, because I always say that our bread and butter is our commercial break.
Absolutely.
And we'll come back. So viewers, we go on a break. Don't go away. We'll be back soon.